Good morning. Thank you all for coming and the opportunity to present. It's kind of funny for me to be presenting to people that have acted as global mentors for me over the years. So this is really not a lecture, obviously, because we're amongst friends. So we'll hopefully engage in a discussion. And I can't tell you how proud I am to be here in Israel and presenting. So thank you for the opportunity. So I'm going to talk a little bit about how we use CT to guide structural heart disease interventions. Again, I know many of you have published extensively in the space, and if I don't cite your work entirely, it's because of a shortage of time. I have a number of disclosures. The ones that are salient just for relevance is that we are the core lab for Edwards and Medtronic now in the low-risk leaflet thickening trial, as well as Neovasc and Tendyne for the mitral space. So I think we all know we've come a long way since 2002 when Alain Cribier did the first transvenous transcatheter aortic valve replacement, and then John Webb, my colleague in Vancouver, did the first transarterial published in Circulation in November of 2004. We saw the first randomized trial data published now, it's hard to believe, almost 6 years ago in conjunction with the TCT and then the New England Journal of Medicine. And we saw that the world of cardiovascular intervention and the management and treatment of severe symptomatic aortic stenosis changed forever, really in 2010. What we saw was a significant risk reduction in those deemed too high risk for surgery that underwent TAVI as compared to balloon valvuloplasty or medical therapy. And while we thought that that was changing the world, and it certainly did, we also realized that there were a lot of limitations. We saw a number of complications in TAVI in 2008, 2009, whether it's peripheral access compromise, whether it was pacemaker rates that have been addressed recently by the group from Teleshomer, as you know, looking at membranous septal length, but also paravalvular regurgitation. And when we look back, it's almost comical that this was the sizing algorithm that was used for the PARTNER 1 trial, looking at a binary cut point at 21.5 millimeters on the base of two-dimensional echocardiography. As I like to say, it was intoxicatingly simple, but woefully inadequate. And the reason it was inadequate are for reasons that we'll touch upon. But we know that through the integration of CT and the modernization of our sizing algorithms, we've seen iteration and improvements not only in the sizing algorithms, but also in the clinical outcomes. I think last week was also a very important week for the field of cardiology. Again, I think the face of cardiology has changed forever with the publication of the randomized intermediate risk trial between surgery and TAVR, published by Marty Leon in the New England Journal of Medicine, where we see with the SAPIEN XT device, which is a historical device in the United States now, even with the XT device and without CT sizing, we can see equipoise between TAVR and surgery in intermediate risk population. And similarly, and this is for the data that we served as a core lab for, if we look at the most modern device, the SAPIEN 3 device, with CT sizing now, you can appreciate if we just look here across all of these potential complications, be it death, cardiac death, TIA, stroke, and so on, that in a matched cohort of intermediate risk patients who underwent SAPIEN 3 TAVR as compared to SAVR, this published by Vino Thorani in The Lancet, these numbers are lower with the TAVR. So perhaps even with modern devices and CT sizing, not only is there equipoise in intermediate risk patients, but perhaps even a risk reduction with TAVI, suggesting that it really should be the treatment of choice for intermediate risk patients. So how can we use CT to help improve the outcomes, or how have we used CT to improve outcomes? I think that we know now that CT is needed to provide a granular assessment of the aortic annulus, that the annulus itself is an almost uniformly non-circular structure, and therefore the two-dimensional echocardiographic sizing methods that were used historically are inadequate. Here we can see that what we're trying to target is the virtual basal ring at the hinge point of the aortic valve cusp. And what we're doing is reconstructing the virtual basal ring described to us by Nick Piazza back in 2008. Now, if we look back how we've used CT over the years, back in 2012 in collaboration with a German and a Danish group, what we did was we simply looked retrospectively at CT integration and whether or not CT could discriminate those patients who historically experienced greater than mild paravalvular regurgitation. And this is almost a silly slide now when we think back retrospectively. It's 4 years old, and at the time what we simply showed is that if you put in a balloon expandable valve smaller than the patient's native annulus, that there was a greater likelihood of leak. I mean, this is so obvious, it's hard to imagine that we would need to show it, but of course this wasn't known, and I think it wasn't known because we weren't using three-dimensional sizing. We also know that CT can provide prospectively sizing algorithms that can help device selection and device sizing. This is our historical sizing algorithm for the SAPIEN XT, looking at the 26 millimeter balloon expandable XT device. And again, what we use is we try to match area, and for reasons that we can discuss later, we use area because we find it to be more reproducible across workstation platforms, and also because it's a more conservative sizing algorithm for the balloon expandable device. Area always overestimates the degree of annular stretch, which some say is its Achilles heel, but I suggest if you're looking at its broad adoption across less experienced sites, it's perhaps more conservative where annular rupture is in the back of your mind. We've also seen sizing algorithms come out for the self-expanding device. Here we can see from Jeff Popma for the pivotal core valve randomized trial, self-expanding device requiring much higher degrees of oversizing owing to the lesser radial force. So again, device iteration and device and the mechanism of deployment will result in different sizing algorithms being needed. But nonetheless, I think again, we've seen excellent outcomes with a self-expanding device on the basis of CT sizing. And then similarly, and pardon the cutoff here, I'm not sure why that is, but we published on the basis of I apologize, on the basis of the European SAPIEN 3 experience that the degree of oversizing needed for the SAPIEN 3 device is more modest than for the SAPIEN XT device. So you can see here that even at modest degrees of annular area oversizing, the rates of mild paravalvular regurgitation are well less than 50% that of SAPIEN XT. And in fact, recently at ACC, the Columbia group showed us not only do you not need to oversize as much, perhaps it's actually beneficial not to oversize the SAPIEN 3 as excessively, because the SAPIEN 3 really likes to be expanded fully. So it's got that sealing skirt that mitigates the rates of paravalvular regurgitation, and in fact that skirt, though, impacts its ability to expand fully when you oversize greater than 20%. So we've also seen how CT has been able to move from theory to practice. We prospectively enrolled patients. This was the first prospective trial that tried to show how CT could help reduce paravalvular regurgitation. And again, it's not CT versus echo, but it's CT, it's augmenting this device selection and sizing process with CT. And we were able to reduce the burden of greater than mild paravalvular regurgitation without an impact on downstream events. How about using CT to reduce coronary occlusion? We know coronary occlusion is a feared but rare complication. And in the early days of TAVI, I know we all talked about measuring in a fashion that was respectful of the anatomy, often obliquely integrating the oblique nature of the sinus as well as the length of the aortic valve cusp. The problem with measuring this way is it's highly non-reproducible. So while this is less anatomically perhaps accurate, it's certainly a much more reproducible method. And what's important, and what I always like to say, is it doesn't really matter what's correct. It matters what actually predicts the event and allows you to identify the patients at risk. So this measurement was used. We were the core lab for the trial that was put together by Josep Rodez and Enrique Ribeiro, and that is how we measured the coronary ostial height for these cases. And again, maybe it's not as anatomically accurate, but it's highly reproducible. And importantly, when we measure the coronary ostial height in this fashion, you're able to predict risk. Here you can see that when the left main height is below 12 millimeters, there's an increased hazard for coronary occlusion. In addition, when the sinus of Valsalva is less than 30 millimeters by mean diameter, cusp to commissure, the risk is again heightened. So when you integrate these two measures, you're able to discriminate risk in advance of the procedure. All of this I know you're doing routinely in your clinical practice. Here an example from our site. You can see a heavily calcified valve, an annulus with an area of roughly 3.6 centimeters squared and 21 millimeters. That's a fairly reasonable-sized annulus and a small sinus of Valsalva. You can see the coronary ostial height is only 9.5 millimeters, and the sinuses measure less than 27. So it doesn't mean that the patient shouldn't undergo TAVI, but it is something we would flag for our proceduralists in advance, suggesting that the hazard for coronary occlusion is perhaps 5 or 6-fold higher. How about screening for valve-in-valve? You know, I've had the opportunity and privilege to work with Danny DeVere, who I know is known to all of you here in Israel, and he has taught me a lot. And one thing that he's taught me is about mechanisms of coronary occlusion in valve-in-valve. You know, when I started measuring for valve-in-valve for John back in the day, I'm a simple radiologist. I measured the same way, and then over time I realized, this is probably not an accurate way of measuring. And the reason it isn't an accurate way of measuring is because you have to understand the mechanism of coronary occlusion that's occurring in valve-in-valve. Now, there are fundamental differences between the devices that I'm sure you're aware. And Vinny Bapat has shown nicely that the reason the mitral flow is at higher risk is because the leaflets are sewn externally. So that puts the mitral flow at a much higher risk. In addition, these sutureless or stentless valves are higher risk owing to the tubularization of the aorta. But the other important thing to note is something that Danny and the group from Medtronic put together, which is very nice. The mechanism of coronary occlusion in the setting of valve-in-valve reflects the formation of a covered stent in the root of the aorta. When the transcatheter valve is deployed here within the bioprosthesis, the leaflets of the bioprosthesis are flipped up. If they're externally mounted, the risk is even higher. And then it forms essentially a covered stent. And if the sinuses are shallow, if the device is tilted towards the coronary ostia, and if the coronary ostia are low, the risk is increased. So what we tried to show in this paper, and now we're doing the analysis for Danny in the valve-in-valve registry of patients who experience coronary occlusion, is that while coronary height is important, sinus valsalva height and width is important, but there are other important things that are related to the surgery that are very much drive risk, and that's the distortion of the underlying anatomy. So that we need to understand the risk in relation to the location of the bioprosthesis as it relates to the coronary ostia. So you can see here very similar sinus geometry, but if the device or the bioprosthesis is tilted towards the left main, the risk is going to be heightened. So we propose something called this virtual ring to coronary ostial distance. It's not anything fancy at all. We simply put in a virtual stent, the size of the device that will be deployed, along in the plane of the, that can't be right. Okay, that's tilted towards the coronary ostia. And here you can see, in this case, the risk would be heightened. The virtual ring to coronary ostial distance is below 3 millimeters. So here you could see some examples, the calcified bioprosthetic leaflets. You put in a virtual stent. You can appreciate there's minimal additional room. This patient's at high risk. On the other hand, this is a very capacious sinus, a mitral flow, potentially high-risk device, but low risk based on the patient's anatomy and positioning. Annular rupture, I think we all know that annular rupture is a bad thing. It's associated with a very high mortality when uncontained. And what we tried to show is that pre-procedural CT can provide you insight into the potential mechanism of risk. When you have severe subannular calcium and you oversize greater than 20%, the risk is significantly elevated. Here you can see two historical examples, oversized excessively on the basis of the limitations of two-dimensional echocardiography. You can see in this case, though, the proceduralist got away with the procedure, even though the degree of oversizing was really excessive, but there was no subannular calcium. On the other hand, this case from Catania in the registry that we put together had severe subannular calcium, and the patient experienced rupture and died on the table. Building upon this, Nikolai Hansen from Aarhus did a much more elaborate calcium assessment. It's been shown before that the ruptures are occurring below the left coronary cusp in this area of what they call locus minoris, this area of weakness. But the reality is it seems that the mechanism of a rupture actually reflects calcium below the non-coronary cusp with a contra-Q injury below the left main. So that you're much more likely if you have high subannular calcium below the non-coronary cusp to have rupture than if you have calcium below the left. So it's some interesting sub-analyses. Of course, I see Dr. Lotan has entered. We know, when it comes to procedures, these are relative risks. It's not an absolute risk. The risk of rupture is perhaps 18-fold higher, but still the absolute risk is perhaps 18 out of 150. So it doesn't mean that the patient shouldn't undergo TAVI, but it certainly informs, I think, the decision. I wanted to talk about pacemaker and some of the great work from Teleshomer, but for sake of time, it unfortunately didn't get included, but that's a very important component in pre-procedural screening. But what else can CT show us with regards to thrombus detection? I remember I got a call from Bjarne Norgard from Aarhus. He called me when he was first doing these cases and said, I think I found something funny here, Jonathan. The echo is normal, the gradient is normal, but I see leaflet thickening. So I said, send us the cases. And sure enough, this is what we saw. There's no question there's leaflet thickening here, and at times significant restriction in opening. Then Gregor Pacha also published an EHJ from Bad Kreuznach, and finally, of course, the Cedars group with Copenhagen published in the New England Journal. What we see here is CT has opened Pandora's box. We see leaflet thickening. There was no clinical indication. We did CTs. We found leaflet thickening. Now we have to understand what to make of it. How often are we seeing it? What is the impact on outcomes? Right now, I think we're not sure what to make of it personally. We haven't seen any link with clinical outcomes beyond the single marker or signal from the New England Journal paper, where in patients with reduced leaflet motion as compared to normal leaflet motion, there was an increased incidence of transient ischemic attack. These were site adjudicated. There was no neurological assessment, so it's a very, very soft signal. That being said, I think it is an opportunity to learn. So as part of the low-risk trials, the randomized SAVR versus TAVR that Medtronic and Edwards are doing, 40% of those patients will undergo CT at 30 days and 6 months. We will serve as the core lab, and those are going to be blinded results. What do I think personally? I think there's an opportunity here for CT to help inform the field. What we see is, this is from Philippe Pibereau and Josep Rodez, a registry published in JACC just this year. What you can see here is if you look at TAVI valves as well as surgical valves, a certain number undergo premature structural heart valve degeneration, roughly 5%. And if we look at the prevalence or the incidence of leaflet thickening in all of these registries that we've seen to date, it's roughly 10 to 15%. Now, we don't know, but perhaps rather than having to anticoagulate 100% of patients, perhaps CT at 30 days will help you identify those patients with leaflet thickening that may benefit from anticoagulation to help reduce the burden of early structural valve degeneration. This is just hypothesis, though. Moving on in the final 7 or so minutes, I thought I would talk about where we're going in the mitral valve. Obviously, we have some true thought leaders in the realm of mitral valve assessment, and we're trying to learn from a lot of the literature that we've seen over the years about how we can use CT to help guide transcatheter mitral valve interventions. I think that, not surprisingly, what is CT? CT is an anatomical test and should allow for a granular definition of the mitral annulus. For years, though, when we started looking at CT in 2014, I had the privilege of meeting Dr. Levine at ACC, and he told me 2 things. He said, the mitral annulus is saddle shape, and then the other thing he said is you should speak to Dr. Schwamenthal about the mitral annulus. So we'll talk later at 10:30. But in the meantime, I'll tell you what I've learned from Dr. Levine's work is that this saddle-shaped annulus was felt to be a limitation for CT, that we simply weren't going to be able to measure the saddle-shaped annulus. Well, the reality is, of course, we can measure the saddle-shaped annulus, and we can do it in a very reproducible fashion. Here, this is a paper we had just last year looking at the use of the Circle software simply by segmenting the mitral annulus all the way around the mitral annulus, 16 points, and I know that there are groups that are looking at model-based segmentation that may even be able to automate this routinely from a CT. And we can create this saddle-shaped annulus extending from the posterior mitral annulus at its insertion along the posterior aspect of the annulus, all the way through to the fibrous trigones, and then the aortic peak extending up. But what we've also learned from CT is that the saddle-shaped annulus that was taught to us by Dr. Levine in 1989 may be anatomically correct, but it may be totally inappropriate for sizing of a transcatheter mitral valve device. Here you can see when I started doing these segmentations, I thought to myself, wow, that's a big annulus. And while it's saddle-shaped and non-planar, the engineers are defining devices that are very much planar. They sit in a space. And if the engineers if we put in a valve the size of a saddle-shaped annulus and project it in a single two-dimensional plane, it would almost certainly result in LVOT obstruction. So I thought to myself, you know, what kind of crazy engineers would they be that they're going to put in an annulus, put in a valve that big into the LVOT, the size of the saddle-shaped annulus? And I realized that perhaps this is not appropriate for device selection, but in fact what we should do is rethink the mitral annulus and desaddle it. If we're to desaddle the annulus and actually truncate the annulus at the trigones, you'll result in a D-shaped annulus that will be much more respectful of the LVOT, and I think very much sit in the site of in what we call the contact zone, or the deployment zone of the mitral annulus. And importantly, what we can see here, essentially with every device, with the exception of one now that's been deployed in man, there's conformational similarities between the implanted device and this D-shaped annulus. This is the Neovasc device, which has been pioneered by Shmuel Banai from here in Tel Aviv. And here you can see the D-shaped configuration. What else can CT help us with? CT can help us looking at landing zone characterizations that may make someone a candidate or not a candidate for the various devices. Here you can see the Tiara. It has tabs. It requires a posterior shelf. The paddles of the Fortis device that requires that the patient not have prolapse. The barbs of the Cardiac Q, which was purchased by Edwards. And the Neocord of the Tendyne device that reshapes the ventricular apex. So here are some examples. Here we can see the posterior shelf persisting in diastole and systole in this non-ischemic FMR patient. Here you can see a much larger posterior shelf reflective of the inferior infarct in the posterolateral infarct in an ischemic FMR patient. So this would be a good candidate for a Neovasc. Here you can see again using CT, we can see, and I never really appreciated this, it's amazing how ignorant I was. In a normal patient, the atrial and ventricular myocardium is very straight. But the engineers realized, and I'm sure that I can see Ehud is shaking his head, that you can see these shelves developing, and the engineers took advantage of this shelf that occurs in the setting of FMR. As the annulus dilates and remodels, particularly in the setting of infarction, you get this posterior shelf. Similarly, in prolapse, and this is why MVP annuli are bigger, you get this mitral annular disjunction where you get atrialization of the posterior mitral valve annulus, which I was very excited that I thought we discovered with CT, but was actually described in 1987 in a large PATH registry the year of my bar mitzvah, so I didn't really uncover it. Nonetheless, landing zone characterization as well, one of the Achilles heel of CT, calcium. It's good, though, for mitral assessment. I'm going to close with two other things, and that is using CT for coplanar angle prediction. We use CT. I know you use CT routinely for TAVI to predict a coplanar angle for the aortic valve. So why could we not do the same for the mitral valve? This is not rocket science. These are blood pool inversion images, virtual fluoroscopic images, in this case from the through Mencio software. And you can see we can provide coplanar angles that are coplanar to the TT line, or the trigone to trigone, or CC line, and one to the septal to lateral projection. The issue, of course, is that the TT view, which is preferred by the interventionalist, is not feasible. It's almost always severely caudal, severely RAO. There's the A2P2 projection, which is not as optimal. So then we can provide this S-shaped curve, really allowing the surgeon or the interventionalist the angle that he or she would prefer, and then provide an en face view, which actually allows the proceduralist to actually angle his or her hands in a projection that would allow coplanarity or tangential deployment to the mitral annulus. In addition, we saw the proceduralists at our site putting in a wire, and we heard, it was actually a recommendation from John Webb and from Shmulik, and what they said was, we'll put in a wire, and then we'll know where we are fluoroscopically from the mitral annulus. But then we humble CT imagers, we said, I don't want to disturb the party here, but you're making an assumption that the coronary sinus is in the same position in all patients with a mitral annulus. And of course it isn't. In some cases it's very tight to P2. In some cases it's a long way away from P2. So what we've done here is we simply did a central line segmentation of the coronary sinus and then projected on the image so that when they're in the procedure, they know when they put in the coronary sinus wire, in this person it's going to be 4 centimeters away from the mitral annulus, in this person it's 1 centimeter. Again, the CT is used now routinely in this very uncommon procedure, granted, but you can see that it's playing an important role in defining these coplanar angles that help to decide the areas of deployment. And I'll close here on the last 2 issues, which are LVOT obstruction and access localization. And the reason I want to is that there are many people in this room that are much smarter than I were with regards to hemodynamics, and I think this is an important question yet for the field. You know, we know that LVOT obstruction is really the most feared complication of TIMV and something we need to understand. And when we started, we thought we would just measure diameter, which was obviously very naive and oversimplified. And then we look at things like residual LV function, septal bulge, the degree of angulation, and so on. But I think what we really need to do is really rethink what's happening in the setting of TIMV. And so we propose this neo-LVOT as the first step to start rethinking it. In the native, the LVOT is an elongated structure defined by the anterior mitral valve leaflet, the intervalvular fibrosa, and the basal septum. When you put in a device, that device narrows the LVOT, and we would suggest there's a neo-LVOT now defined by the anterior margin of the AML as well as the device, and then the path of the flow of blood is now disturbed. It's changed very much, and it heads out in a different fashion. And we think this is important as the first signal to determine potential risk. We know that there are many mechanisms of obstruction, including device protrusion, flaring, the angulation, and the septal bulge. But we're trying to learn from post-implant images how we can predict the risk of LVOT obstruction. Again, here's the native LVOT, but in the setting of this Tendyne device, the neo-LVOT is now narrowed and elongated with the path of flowing blood in a very different direction. Here you could see in the native setting prior to the TIMV, and here post-TIMV, what we're simply doing is we're getting orthogonal and looking down the barrel at this device. Here's the TIMV device, the Tendyne device, and here's the neo-LVOT, which is preserved. So what we do is if we're looking at a patient where they're going to put in a SAPIEN device, we simply put in a virtual stent and we create this neo-LVOT, and we look down the barrel, short axis at the site of the minimal residual distance, and we look in diastole and systole and look at the neo-LVOT. Here you can see in the setting of MAC, where they were considering a transcatheter mitral valve in MAC, that if we look at the residual space in systole, there's absolutely no room. This is almost certainly going to cause LVOT obstruction and mortality. So we're using CT in a somewhat simplified way still, clearly CFD or some sort of more thoughtful analysis to predict residual gradients. Obviously loading conditions, volume status, device positioning, all of these things are going to impact it. And that's why I think this device positioning is an important factor. And the last way we use CT right now for TIMV is to guide the transapical localization. When we started doing TIMV, we realized that it was time that CT started to reassert itself to guide the apex localization. And the reason is, you know, the people at our site said, we know how to get the apex, Jonathan. We've been doing TAVI via apical localization. I mean, Sam Lichtenstein first did that in 2005. So he said, you know, we don't need help doing this. But the reality is for TAVI, they don't need help. But for TIMV, I think you do. Because if you go in with a transcatheter mitral valve device and you localize the apex, even if you just go off a little bit, they don't go right off the apex, you come very obliquely towards the mitral annulus. And you come in a very oblique shot, and the likelihood of canting the device and tilting the device is significantly elevated, and it can cause LVOT obstruction or leak. But what CT can do is we can now, by simply segmenting the mitral annulus and defining the center point or the centroid, you can simply get an access point that extends from the centroid all the way out to the apex, or all the way out to the epicardial margin, providing you now an annular trajectory that's perhaps more relevant for the transcatheter mitral valve intervention. And then we can simply transpose that on the epicardial surface of the heart, and even transpose it further if you have the entire thorax to look at the actual interspace to define for the procedure. So again, I thank you for your attention. It's a real honor to be here, and I hope you found that of interest.